Hello, welcome. We're going to have a little session of digital pathology sign out with the professor today. Severely disrupted from the normal schedule by this little CrowdStrike glitch that came to pass last weekend, last Friday, and put off our session for today. But I'm glad we can put it up today and share with you some interesting cases. So let me jump to that, and we'll get started with a sequence of cases that would be of interest and I hope helped you in your daily practice. So we're going to talk today about a number of soft tissue tumors that can have an inflammatory component. This is, I think, a challenging area for pathologists in some respects because many times the inflammation can be deceptive, and we think that this is truly an inflammatory process rather than the more ominous and potentially life-threatening neoplastic process. So here's the first case. This is a retroperitoneal lesion. As you can see, we have sort of a mixture of hemorrhagic areas, some pale, modestly cellular areas, a little bit of interspersed fat, perhaps residual here, and then some degree of inflammatory type cells here. So this shows you here sort of a mixture of edematous cells, some variable sized nuclei, a few larger nuclei here. And you see this process has some areas of more spindle-shaped cells and really quite open nuclei, spindle-shaped proliferation here. But interspersed then are these mast cells, a few plasma cells, and so forth. So in a mesenteric or retroperitoneal mass, this could be concerning for a variety of lesions. I think if you saw much of the spindle cell component here, you might not be quite as inclined to dismiss it as purely inflammatory. And so that might lead to a sequence of considerations. So this is actually an example of one of the lesions that we think about in this process. Here's another example occurring in a very superficial location. Again, a mixture of lymphocytes and some plasma cells in here with a little bit of atypia, some vasculature, and so forth. A similar sort of lesion sort of in the head and neck. And then here, a slightly more deep version, a little bit more cellular, some altered infiltrative appearance around some smooth muscle bundles, and showing you this picture of mixture of cell types with a sort of underlying vaguely spindle cell type of lesion. Now, when we come to immunohistochemistry on this lesion, we tend to get features of myofibroblasts. So we may get a mixture of cell types. Here's another example. I think this one from the lung. I think you can see here. And again, it's quite bulky and a little bit spindle-shaped. And then these admixed inflammatory cells here. And this streaming character, almost sort of tissue culture, is reminiscent of other sort of myofibroblastic lesions like nodular fasciitis and so forth that have this fairly monotonous appearing, not pleomorphic, but very often very active mitotically appearance for these lesions. So as I was saying, these tend to type out as myofibroblastic cells. And in fact, so we would see that they tend to be positive with some of the myoid markers variably. And then comparing them to other lesions, they tend not to have, markers of CD10 or the GIST markers and so forth. They don't have the marker for desmoid fibromatosis sort of things, but very often they will be ALK positive. And you may occasionally even get a little bit of CK and so forth and have CD99 positivity. Hormonal receptors, unlikely, variable, and so forth, but those are some of the immunohistochemical features that you can see. Now, you'll see some of the other things that might be considered. This was from our presentation earlier on such a lesion in the pelvis, comparing it to other things that might be considered there. And we'll talk a little bit about some of these other lesions later today. So here's an example of some of the immunohistochemical findings you might expect. This is, I think, an actin stain, although it could be desmin as well, and fairly cellular and positive staining. Here again, CD10, you can see the positive staining in the control, showing that you can get some positive staining with this with CD10, and that can be confusing if, for example, you're thinking about an endometrial stromal sarcoma or something of that sort. But this doesn't have the vasculature in quite the same way, and the admixed inflammatory cells would be uncommon for that. Here's the desmin. Showing here negative reactivity in this lesion. So inflammatory myofibroblastic tumor is something we can see in a variety of locations, certainly lung, head and neck, fairly frequently, but also in the GI and GYN tract, retroperitoneum, and so forth. These are areas where sometimes the differential can be quite interesting because of that contrast. Now, these tumors do have some degree of aggressive behavior. They're classified as sort of intermediate grade neoplasms. And as we've indicated, usually have some sort of gene rearrangement that leads to activation of ALK1 most frequently, but other gene partners can also be expressed in some of these. So in the GYN tract, of course, we've indicated these are relatively uncommon, and depending on the pregnancy status of the patient, may be a little bit more benign than in other locations. So a nice set of examples of inflammatory myofibroblastic tumor. And of course, the link to the digital slides for this presentation will be made available to you, so you can come back and study those examples in the various sites that I've included here. All right, so here's another lesion that can have significant inflammatory component. Here we see this sort of encapsulated lesion, and if you've been following my channel, you may recognize this as the one we did a short presentation on recently. And it has this sort of pseudocystic or open space component to it. We can see that it's got not inflammatory cells here, but sort of a epithelioid to slightly spindled appearance, and there may be a few inflammatory cells in this area as well. A few foci around vessels may have this process, but then most strikingly off to the periphery, we often have this cuff of lymphoid inflammatory cells here, and we see it down here as well, even with a vague sense of maybe granuloma or other clustered histiocytes there, maybe some multinucleate cells along with this. So this is a very characteristic description with this sort of slightly fibrous capsule, peripheral cuff of lymphocytes, this sort of pseudocystic or telangiectatic type space there. And You may also have areas where you can find some hemosiderin. I think there may be a little bit of hemosiderin in here. Sometimes these lesions have a fairly chronic history of bleeding that may lead to hemosiderin deposition. Maybe here there's some as well. You can sort of see a little bit of that golden brownish color here to indicate there's been some chronicity to the hemorrhage. So another example of this case, I think I've got a couple of examples. A similar lesion, similar features that we emphasize: the fibrous capsule, the sort of pseudo-telangiectatic or ectatic cystic type spaces, and then these somewhat nodular epithelioid to slightly spindle-shaped cells, intervening vasculature, and moderate amounts of hemosiderin potentially being present. You can see quite a bit of it here, indicative of this lesion, which is, this is the angiomatoid fibroblastic histiocytoma, angiomatoid fibrous histiocytoma. Again, a lesion of somewhat intermediate neoplasia. Here's an example from the skin at the low magnification. You can see, again, very nicely this peripheral cuff of inflammatory cells, the fibrous capsule, the angiectatic type spaces, areas of hemorrhage. This doesn't have very much hemosiderin in this one. I think it's a fairly recent one, hasn't been around very long. These lesions also tend to have somewhat of an intermediate behavior, do have the potential for spread or recurrence. And so a good excision is usually the most appropriate treatment. They do tend to be somewhat more superficial, not in the deep fascial, they're deep to the deep fascia, and most commonly is seen on the extremities. So that's another nice example of one of these intermediate soft tissue lesions that can have an inflammatory component as well. Now, another lesion that presents in this category is this lesion. Here again, we can see this is here's the superficial surface, the skin up here. We have the dermis and then subcutaneous fat. And so this lesion is sitting kind of right on the deep fascia. You can see that it's somewhat nodular, that you've got this mixed pattern of edematous tissue, sort of like nodular fasciitis sort of thing again. But when we come into higher magnification, we don't see quite the same picture as we do with nodular fasciitis. There's a fair bit of pleomorphism to these cells. We see some triangular cells, some bizarre cells, and you may find some atypical mitoses as well. But then in the background here is this inflammatory process that gives us some of the features of this lesion that we are used to seeing. As we think about this lesion of this degree of atypia, this is something that previously would have perhaps been termed inflammatory MFH or something in that categorization. This is what's now called myxoinflammatory fibroblastic tumor, and does tend to also have this extravasated red cell background as well. These lesions are a little bit more aggressive than the previous two lesions that we've discovered, but tend to be, again, because they're superficial, tend to be discovered a little bit earlier and hence resected a little bit sooner. And so they can have a reasonable prognosis in terms of outcomes. So that's a myxoinflammatory fibroblastic tumor. I don't have other good examples. This is a fairly uncommon lesion and not something that we see with any degree of frequency. So coming back to the deep tissues, intra-abdominal tissues, a lesion that can overlap with this process is represented in this slide and the next couple of slides, where you can see we have sort of lobulated fatty tissue with a kind of a paniculitis type of appearance, quite a bit of inflammatory cells. And I think you can appreciate that there's probably some plasma cells in here along with the lymphocytes and these larger histiocytoid type cells. So it's a mixed pattern of inflammation. And then we get a sort of a loose fibrous or myxoid tissue in between the fat adipocytes, creating a loss of or an increased density to the tissue, a little bit more firm fibrous character to it. So there's a degree of what might be termed sclerosis. You begin to see maybe a little bit of wavy collagenous fibers in a few areas in this lesion. This is also an entity that we've covered earlier in one of our videos, specifically on this topic, which I'll put the link to. But this is a lesion that tends to occur on the deep to the bowel in the mesentery, and can come right up and abut the muscularis propria. This is an example from our files showing you this extent and the severity of this lesion as it progresses. It is that it obliterates the fat and leaves you with this very sclerotic pattern of tissue that, as you can see here, comes right up to the muscularis propria, and actually the inflammatory process appears to come in towards the inner table of the muscularis propria as well. So this pattern, this would be uncommon for a GI stromal tumor. Of course, those are going to occur primarily be centered on the muscularis propria. This is centered in the adventitia. And with this degree of sclerosis, and as you can see here, still this mixed inflammatory pattern here, so quite a bit of eosinophils along with the plasma cells and so forth. So we might wonder, well, is this an IgG4 related disease? Possibly it is, and it certainly would be worth considering doing differential IgG and IgG4 stains to see if you have a preponderance of IgG4 positive cells. But this is the category of what's been termed sclerosing mesenteritis. And it's a potentially quite devastating disease because it does tend to affect the bowel and restrict motility, creates a mass mimicking malignancy and so forth. This does not tend to metastasize, but certainly recurrence, if it's not properly managed, would be a great concern. And certainly secondary symptoms, morbidity due to bowel obstruction or dysmotility would become an issue. Aside from the IgG stains, there's not anything else that's specific in this situation. Here's an example of a lesion seen on frozen section. And here, this is actually from this same case. You can see scattered inflammatory cells and this very pale, loose tissue. This was reassuring in the sense that we're not dealing with a high-grade sarcoma, we're not dealing with a GI stromal tumor or something of that sort. But making the diagnosis on frozen section might be a little bit challenging if you don't have a good clinical pathologic correlation. But in discussion with the surgeon, we were able to suggest this possibility. So typical other mesenteric masses that we might see, neoplastic sorts of things, desmoids, inflammatory myofibroblastic tumors, and so forth. All of these fit into this category of possibilities. And then the benign lesions includes sclerosing mesenteritis, tuberculosis, and so forth, other sorts of things. None of these other benign lesions would give you this sort of sclerotic appearance on frozen section. And certainly, aside from desmoid or inflammatory myofibroblastic tumors, possibly liposarcoma, your frozen section is going to be fairly bland. GI stromal tumors and desmoids would have more cellularity usually. Inflammatory myofibroblastic tumors, the other one that we might have difficulty distinguishing here. So that's where you might land in terms of your frozen section interpretation if you were presented with this lesion on frozen section. These, as I've indicated, some patients may have IgG4 disease. This mixture of fibrosis, inflammation, occasionally fat necrosis. These are usually solitary single masses. And the patients tend to have inflammatory markers, elevated complement factors or other sedimentation rates and so forth. Those sorts of things can be enhanced. Radiographically, this has been described as kind of the misty mesentery. It's a great term. I'm sure that some radiologists enjoyed dreaming about that in their dark rooms. But aside from that, there's nothing specific. Unlike other IgG4 disease, this tends to be stable, doesn't seem to be progressive. So if it's not massive, it may not produce symptoms, or they may just be very nonspecific. In terms of workup, this is kind of the assessment, CT scan, reviewing that and so forth. Ultimately, you may have to come down and look at what the lymph nodes are involved and so forth. This was kind of an interesting look at it from a radiologist standpoint in terms of the potential evaluation. For sclerosing mesenteritis, they like to have at least 3 of these 5 criteria: a mass that encompasses or displaces structures, hyperattenuating fat with some nodular soft tissue like lymph nodes and so forth, the so-called fat halo sign, or some sort of a pseudocapsule associated with that. Those are some interesting considerations that I think ultimately the radiologist can suggest it, but you're going to need some histology to make that diagnosis. So another entity that fits into the differential here, we've alluded to already, is dedifferentiated liposarcoma, which can have quite a significant inflammatory background. And in fact, the well-differentiated liposarcoma can also have a significant inflammatory component. So here on the right side of this slide is more the well-differentiated liposarcoma with, as you can see, some atypical cells here in the fibrous bands and some accompanying inflammation. Now, you don't need to shift the proportions here too much to realize that you got an exaggerated response of the lymphoid cells here. You could be looking at something that, and a less prominent septal atypical cell component. You could be looking at something that looked very much like an inflammatory mass, very much like that sclerosing mesenteritis in the first slide of that I showed you. So those are things to be considered as you look at that possibility. Of course, with dedifferentiated liposarcoma, you're going to have other more solid areas of dedifferentiation with higher degrees of pleomorphism, atypical cells, and so forth, as we see here. And you may even, on occasion, have areas of heterologous differentiation, which in this particular case even included areas that were forming osteoid. So this is a dedifferentiated liposarcoma with osteosarcomatous type differentiation. So a more atypical and higher grade than the typical dedifferentiated liposarcoma, which typically just looks like undifferentiated pleomorphic sarcoma. Certainly, depending on the biopsy areas of the sampling, you may see heterologous elements or not in this entity. And important to be aware of that inflammatory component, particularly in the early stages, in the less dedifferentiated, the well-differentiated component of this tumor. Now, another entity that can masquerade here, of course, is the IgG4 related disorders that involve the liver, biliary tract, and pancreas. Occasionally other organs. These will provide a very sclerotic mass-like background and can masquerade as a neoplasm. But if they're biopsied, they tend to have this very sclerosing appearance with an admixture of inflammatory cells that often includes eosinophils and plasma cells. So this is actually from a liver biopsy. Here you see a little bile duct. And as you can see, you've got this very inflammatory process going on. I don't see any normal liver here, but we see plenty of this sclerosing fibrous tissue. Well, okay, so here we got a little bit of liver over here with this inflammatory process. And we can see that there's some damage or sclerosis extending into the hepatic parenchyma as well. So in this situation, you might think about some of those other entities we've talked about, inflammatory myofibroblastic tumor and so forth. But considering IgG4 related sclerosing pancreatitis or cholangitis would be appropriate. Most typically, this is a pancreatic type lesion, but here's one again centered around the bile duct with an extra abundance of this dense sclerotic type pattern. You see the inflammation here, lymphoid cells and so forth involving the secretory component. Here we're not seeing a lot of residual pancreatic type epithelium. I was going to say this could even be from the salivary gland as well, but I do believe we're in the pancreaticobiliary tree, and you can get some inflammatory component with germinal center formation as well. So this dense sclerosis, this is very characteristic of the IgG4 diseases, that they tend to produce this very sclerotic appearance, and the acinar tissue is inflamed and destroyed, progressively atrophies, replaced by this fibrous tissue. Here's another example, a little bit less damage to the acinar epithelium. You can see more residual of that, but there's still a lot of sclerosis here and a lot of inflammation and variable amounts of plasma cells. Here, not so many eosinophils, there are a few. And you can see there's also some involvement of the vasculature in this situation. So these lesions can look invasive. They can look like they're involving the vasculature. But fortunately, if we can detect these lesions in the sort of pre-excision stage, I guess you'd say, through a biopsy or through clinical suspicion, these lesions often will respond quite nicely to steroid therapy or other medical management without the need to revert to surgery. So it's not necessarily a surgical disease if we can make the diagnosis preoperatively. Here's another example, a little bit more progressive. So in the pancreas, this lesion can mimic radiographically pancreatic carcinoma. Clinically, it looks like that. You may get obstructive symptoms, diarrhea or weight loss, other sorts of problems, but having that index of suspicion. Now here you can see that the atrophy of the acinar component has progressed to a greater degree. We have very little residual acinar tissue. So the likelihood of recovery at this stage may be lower due to the fact that you've already destroyed a great amount of the acinar parenchyma. But since this doesn't tend to involve the entire pancreas, if you can gain control over this, the residual or reserve in many patients will be sufficient to allow them to function adequately. So autoimmune pancreatitis, this is often insidious symptoms, mass lesion, possible obstruction of ducts mimicking neoplasia. And as we've indicated, many of these are IgG4 related, but there is also a non-IgG4 type of autoimmune pancreatitis that can give you a somewhat similar appearance, usually with fewer plasma cells and a tendency towards granulomatous inflammation. Well, I thank you for joining me. I don't have any additional cases to share with you today. I appreciate your patience and those of you who joined on Friday but were disappointed. My apologies again. And I hope that the various computer glitches have affected you less severely than they have affected me, disrupting my life and plans to a very significant degree over the past few days. But fortunately, we've been able to recover and hope to get to the full recovery stage here in a day or two as well. So I'm going to close a little bit early today and don't see any questions from our participants, but feel free to leave me a comment. I'll post the link to the slides we've talked about, and I do hope that you'll join me next month. We are hoping to have a guest instructor, a new professor of pathology joining with us from our new team that's begun this year. And so until then, thanks so much for joining me.